Let's get right to it. We're going to review the key, practice-changing recommendations from the 2026 Opening Group Expert Consensus on the diagnosis, treatment, and prevention of urinary tract infections. Okay, this briefing is structured right along the clinical workflow. We'll cover 5 critical areas: diagnostics, uncomplicated UTIs, complicated UTIs and prostatitis, prevention, and finally, special population management. All right, starting with diagnostics. We're going to define the updated principles of stewardship. The goal here is simple: reduce inappropriate urine culture requests and the subsequent, often harmful, treatment of asymptomatic bacteriuria. So, the consensus panel tackled several common clinical scenarios where, let's be honest, practice variation is extremely high. The objective was to provide very clear, actionable directives. The panel reached near-unanimous agreement against ordering urine cultures in these 4 very common low-yield scenarios. First, for uncomplicated cystitis, your clinical criteria are sufficient. Trial data show culture results just don't influence time to symptom resolution. Second, in both catheterized and non-catheterized asymptomatic patients, pyuria alone is not a trigger for culture. And finally, the same goes for nonspecific changes like urine odor or turbidity. Now, here is a point of critical importance, especially for those of you in geriatrics and the ED. Acute confusional syndrome as an isolated symptom is an insufficient indication for a urine culture. Let me be clear. Meta-analyses have failed to show that antibiotic therapy accelerates delirium resolution, even if there's concurrent pyuria or bacteriuria. In fact, they've suggested a potential for worse outcomes. Okay, moving on to therapeutics. The guidelines now provide very precise evidence-based regimens for uncomplicated cystitis and pyelonephritis. The aim is to maximize efficacy while minimizing treatment duration and, of course, collateral damage. For uncomplicated cystitis in women, these 2 short-course regimens are strongly recommended as first-line options, and that's with 97% expert consensus. They are prioritized over fluoroquinolones and beta-lactams because of their superior ecological and safety profile. It's also worth noting that meta-analyses have confirmed the non-inferiority of single-dose fosfomycin compared to longer regimens. Now, here's a key update. The guidelines now endorse shorter fluoroquinolone courses for uncomplicated pyelonephritis. A meta-analysis revealed absolutely no difference in clinical or microbiological failure rates between a 5 to 7 day regimen and longer durations. Treatment with beta-lactams, however, should still be extended to 7 to 10 days. Let's now address empirical treatment for complicated pyelonephritis and acute prostatitis. Here, pathogen resistance and tissue penetration are obviously our primary considerations. For complicated pyelonephritis, your first-line empirical agents are 2nd or 3rd generation cephalosporins. For a more severe presentation, you should augment with an aminoglycoside. And importantly, you must avoid fluoroquinolones empirically if your local resistance rates exceed that 10 to 15% threshold. And of course, for patients with ESBL risk factors, you'll need to escalate to a carbapenem or piperacillin-tazobactam. For acute bacterial prostatitis, initial parenteral therapy must be broad spectrum. For your oral step-down therapy, fluoroquinolones are the preferred class. Why? Because of their superior prostate penetration, which is absolutely critical for reducing the risk of recurrence. The consensus strongly endorses a 2 to 4 week total course of therapy. Remember, inadequate definitive treatment is a primary predictor of recurrence here. This next section reviews the evidence for both non-antibiotic and antibiotic strategies for preventing recurrent UTIs, which we're defining as 2 or more episodes in 6 months or 3 or more in a year. Okay, among the non-antibiotic options, the MV140 sublingual bacterial vaccine has emerged with the most robust supporting data. This comes from a recent double-blind, randomized controlled trial that was published in NJM Evidence. In sharp contrast, the evidence for cranberry products is really limited by study heterogeneity, and the data for probiotics are inconsistent, though it's true some vaginal formulations do appear effective. With 100% consensus, antibiotic prophylaxis remains the most effective intervention for recurrent cystitis after non-pharmacological measures have failed. The number needed to treat to prevent just 1 recurrence is exceptionally low, at 1.85. Your standard agents for this purpose are going to be nitrofurantone, cotrimoxazole, cephalosporin, or fosfomycin. Finally, let's cover the critical management directives for geriatric patients and the evolving perspective on asymptomatic bacteriuria in pregnancy. There is 100% expert consensus against treating asymptomatic bacteriuria in institutionalized older adults. This practice provides zero benefit and is linked to significant harm, including an 8-fold increased risk of C. difficile infection. This is a Class 3 recommendation. Do not do it. Now, the panel's position on asymptomatic bacteriuria in pregnancy is more nuanced. While historical data did support routine screening and treatment, you must be aware that recent evidence is questioning this paradigm. Modern cohort studies show the absolute risk of pyelonephritis in untreated women is very low, less than 2.5%, and a clear association with preterm delivery has not been confirmed. This evolving evidence is reflected in the lower consensus of 70%. So, to conclude, these guidelines provide a very clear framework for optimizing UTI management. But the central challenge for all of us remains the clinical application of this evidence. Specifically, how do we balance these strict stewardship directives against the diagnostic uncertainty we face with atypical presentations in our most frail patient populations? That is the core question we must continue to address in our practice.